come front or stay away. So we'll be questioning and asking, what you're going to do. So the lecture will not work without your participation, please. Huh? So what we will do, we'll briefly discuss pathophysiology of ARDS. We'll do the case, it's a real case in our hospital. We'll do it through the two lectures, the first lecture and the second lecture. And we'll discuss briefly what's the pediatric evidence of ARDS and some protocols and latest of the protocols in the management of ARDS. So if you look at the ARDS, you see this white chest X-ray is actually from two-dimensional is different than when you look at the alveoli. So you see the alveoli, if you go deep, this is one of the most quoted slides in ARDS literature, and we need really to understand it. You can see here, the ARDS can start from direct lung injury when there is injury to direct alveolar epithelial cells, or indirect lung injury when there is injury to capillary endothelial cells. You can see that this is normal alveoli and there is macrophage present. So when there is injury to the alveolar, if we take direct injury like pneumonia, the first cells to be activated is the alveolar macrophage. Macrophage will secrete pro-inflammatory cytokines, trying to call a friend. The friend is the neutrophils. The neutrophils coming from the bloodstream, trying to squeeze through the interstitium, trying to go to this damaged alveolar epithelium into the alveoli. So with going in, it brings a lot of interstitial edema. So the classic hallmark of ARDS, the first classic hallmark is interstitial edema. But it's not only interstitial edema, there is also alveolar edema. These inflammatory cytokines release a lot of inflammation with disrupted cells. By time will cause a lot of cellular debris. I just want to review again back the function of these cells. This is very important physiologic thing to know. We have type 1 cells, which is very important to work as a function as barrier of the epithelium. Type 2 cells has three functions. The first function is differentiate into type 1 cells, so it will maintain integrity. It also active in fluid clearance, so it clears the alveolar edema. And the third one is it secretes surfactant. So if we have this dysfunction and this ongoing inflammation, this will create by time deposition of a hyaline membrane. So the second hallmark of ARDS is hyaline membrane. It's protein-rich membrane which will now replace type 1 cells and will cause significant alveolar collapse. So the two hallmarks as we discussed, interstitial edema, alveolar edema, as well as hyaline membrane. So this is from direct lung injury. The same thing can happen from indirect lung injury for something, for example, sepsis will cause capillary endothelial damage, platelets aggregation, microthrombosis, and the inflammation will cascade from this side toward the other side. So one of the important physiologic difference also you need to understand is the difference between pulmonary edema and ARDS. So in ARDS we said that there is alveolar edema in addition to interstitial edema. However, in pulmonary edema, what we are looking mostly as interstitial edema, and this edema because of increased hydrostatic pressure, because, for example, with LV dysfunction causing interstitial edema, and with the bulk flow from interstitial edema to alveolar edema. However, that is clearly can be managed because we still have the active mechanism of type 2 cells that will actively clear the alveolar, the interstitial edema which is present in the alveoli and clear it. But in ARDS, you can see we already lost the mechanism. We don't have active clearance because of dysfunctional type 2 cells, but it's not only interstitial edema, it is actually alveolar edema. You can see here, even the hydrostatic pressure is normal in ARDS compared to pulmonary edema because it's not only high hydrostatic pressure, it is disrupted epithelial alveoli that causing gush of this high protein fluid inside the alveoli that is not easily cleared as pulmonary edema. So this is a real case, 3-year-old girl with type 1 diabetes, came with fever, cough, vomiting for 3 days. She was hypotensive. She received 50 ml per kilo fluid boluses, started on epi, nor-epi, hemodynamic stabilized. We did investigation with the rapid test. It turns to be rhinovirus enterovirus. So initially was in 3-liter nasal cannula, initially in the ward, then came to ICU, started in high flow with worsening chest X-ray, as you can see here, and within 1 day escalated to BiPAP with very bad chest X-ray here. The disease did not progress, desaturation, so was intubated for refractory hypoxemia. So if you go back on diagnosis of ARDS, we have BALIC guideline recently published in 2023, which we'll discuss. You can go here, but I don't have much of time to discuss more of the details of this. But what I need to tell you that we have an ARDS, we use the oxygenation index. Oxygenation index have FiO2 factor in addition to the mean airway pressure factor, and what we get is the oxygen saturation or arterial oxygen content. So we have initially in the old definition, they have mild, moderate, severe. Now what they did is they combined both types, mild, moderate together, if the oxygenation index is than 16, or if you have only pulse ox, oxygen saturation index less than 12. And if the oxygenation index more than 16 or oxygen saturation index more than 12, that will be considered severe. Why they did have two categories? Because the mortality is way high when you are reaching severe form as compared to mild moderate, which is almost similar prognosis. So this is the patient when intubated in the ICU. Now the first question to the audience. Okay, so PEEP is 12. I'm giving you the mean airway pressure 19, plateau pressure 23. This is the blood gas. The saturation is 83%. So does she have ARDS? Yes, otherwise I will not be standing here. Okay, so what's the severity of the ARDS? Mild, moderate, or severe? Severe, okay. What's her OI or OSI? Okay, here. Oxygenation index, just to remember, what we are giving pressure, so mean airway pressure. We're giving also oxygen, so FiO2. And what we are getting, if we have arterial line, we will get the PaO2. If we don't have arterial line, we will get SpO2, so we'll call it OSI. So if you calculate for this patient, since we don't have arterial line, the OSI is 19 multiplied by 100, okay? And the saturation which we are getting is 83, so here OSI is 24. So that is severe ARDS. I just want to tell you here, this is the severe again, more than 16 on OI, more than 12 in OSI is severe ARDS. So management, so that's important, that's what we are studying. I'm not doing a lot of theoretical stuff. It's not really helpful at the bedside. So theoretically, what should we do? So now saturation is 83, PEEP is 12. I don't know in Kuwait or other, you guys, what you will do. Will you continue in conventional ventilation or switch to other machine, high frequency oscillation, for example? Or will you change the position? So this is supine, this is prone, and prone, some people thinking that we'll have better ventilation perfusion matching, we'll have less atelectasis, so we'll improve. So which one you will choose? Or will you choose both? Or you will stay with the same thing? Prone? Okay. So this is BALIC again, BALIC recommendation. If you go in BALIC recommendation, it's very nice here. You can see the oxygenation index or oxygen saturation index. What they did here is you can see the severity is going up. That's why it's important to know the severity. And we are around 25 here. So if you go here, very low certainty, moderate certainty, and cannot recommend. So let's see here. PEEP at or above low PEEP high FiO2 is moderate certainty. That's what they said. Inhaled nitric oxide, nobody said nitric oxide. They said low certainty. What did you guys say? You guys, brown, right? A lot of you say brown. So here, brown. Gray. What does it say here? They cannot recommend. For again, so they like do gambling. You do it or not, don't do it. So the recommendation by the expert left you blind. They did not advise you what to do. So prawn, high frequency, again, same thing. Recruitment maneuver, they same thing. So what I'm going to discuss in the next few minutes and the next lecture is these three things. These we're not going to discuss because it's discussed already by other people. So this is quickly the studies recently, if you want to go and see. Here the finding is the important finding here. If you see this low tidal volume, the ARMA trial, the only study which showed improved mortality in adult ARDS, 22%. But if you look all of these here, no mortality benefit for everything. High PEEP, low PEEP, recruitment, PEEP titration. I'll just go quickly. High frequency, no mortality benefit here in neuromuscular blockade. Initially in 2010, they found some improved mortality, but then they repeat the study in adult and no mortality benefit. So still no mortality benefit. Prone positioning in pediatric, no benefit. In adult, there is benefit in 2013, adult ARDS. But we are talking about pediatric ARDS. Fluid, no benefit. Surfactant, no benefit. Steroid, no benefit, except this is COVID, ARDS. Adult, there's benefit, but usual other causes, no evidence. Nitric oxide, no benefit. Even a lot of things other than that, vitamin C, statin, no benefit. So what I want to discuss with you or introduce you to a study called Prospect. Prospect is a prone and oscillation pediatric clinical trial, which is ongoing currently. And that's want to verify if any benefit of a prone versus supine or conventional versus high frequency in pediatric ARDS. The protocol was published in September 2024. You can read it if you're interested more about it. So the rationale is, in pediatric, as we discussed, the previous study, the only previous randomized controlled trial in pediatric ARDS about proning, did not show any benefit. However, there's concern, and I will discuss in the next slides why it's not very helpful. Same as ARDS with two negative trials, so we really need data. And we are targeting high, moderate to severe ARDS, pediatric ARDS. We're not talking about mild ARDS. What we want to see is there any benefit of ventilator-free days if we are using prone positioning versus supine or using high frequency versus conventional. So if the patient came with moderate to severe ARDS, well, the patient will be randomized to one of these arms. So conventional, 2 arms with supine or prone, and high frequency supine, high frequency prone. So he will go in one of each arm, and then the outcome is ventilator-free days, or how many, or does it have benefit in ventilation? So it is a multi-national site. United Arab Emirates is one of the country which part of it, Sheikh Khalifa Medical City, our hospital. So all over the countries here, Abu Dhabi, SKMC is participating in this trial. This is the meeting with many investigators trying to discuss the recruitment. Here I am in the back if you can recognize me there. So the inclusion criteria, we include any except neonates. So above 2 weeks of age until 21 years of age. Those patients who have moderate to severe ARDS, they should meet the criteria and not exceed more than 2 days. So if they have ARDS, they should be randomized within 2 days of meeting that criteria. Otherwise, we cannot keep them with other management and then put them on the outcome. How we diagnose them? We diagnose them whether we have oxygenation index more than 12 or oxygen saturation index more than 10, so that's moderate, but we need to confirm in 2 hours, so twice, or if the patient already has severe ARDS by oxygenation index more than 16. Those and should be also intubated less than 4 days. Should not be intubated more than 4 days. This is the exclusion criteria. Essentially, we are excluding anyone who will not be extubated normally. Critical airway, a lot of other issues which will affect the extubation, because that's our outcome. And or any issues with proning. So if we cannot prone them, unstable fracture, open abdomen, or increased ICP, this will be excluded. Or it will affect the prognosis. For example, DNR, ECMO, all these things, they will not be included. So positioning, so 16 hours of proning per day if he's randomized to proning. Otherwise, he will be supine. Will be staying prone if he randomized until his oxygenation index less than 8. So he is improving. We will stop proning if OI less than 8. So ventilation will follow the recommendation of Balik. I will discuss that next. Same thing with high frequency oscillation. So if you look at the previous trials, so in terms of positioning, proning versus supine, this is the adult trial which had improved outcome in proning. But in pediatric trial, which done also by Dr. Curley, did not show any benefit. But the drawback on this trial is that they use PaO2, FiO2 ratio less than 300. Less than 300 is including all ARDS, mild, moderate, severe. But we know from many studies, including this study, is that proning will be beneficial only in moderate to severe. So that's why probably there is no outcome benefit in that trial. And that's why we restrict our study to those patients who are severe ARDS. In terms of high-frequency oscillation, this is the adult trials, OSCAR and OSCILLATE. OSCAR, no benefit. OSCILLATE, there is trend toward mortality on those who are high-frequency. That's why our adult colleagues stopped doing high-frequency. We don't believe in their study because what they did is you can see what the initial high-frequency is very low. So that's against the protective lung ventilation compared to our prospective trial, which try to use high frequency, gentle, low tidal volume. So they use this, which is, of course, going to have bad outcome. The other thing is they use one size fit all. So what they did is they did not personalize the mean airway pressure. They, in oscillated trial, they put everyone at 30 centimeter mean airway pressure after recruitment. And on this, they did 5 centimeter above. And of course, this high pressure will, of course, cause more hemodynamic instability, which has been seen in oscillated trial, plus bad outcome. What we are going to do here is we're going to do optimal mean airway pressure.
You have 2 minutes.
Inshallah. So, ventilator management. Okay, so this is the guideline for prospective trial. If the patient is randomized to prospective trial, we target saturation 88 to 92 during the acute phase. We target pH 7.15 to 7.3 during the acute phase. We don't care about PaCO2, irrespective of PaCO2. We will calculate ideal body weight. We'll use ideal body weight, not actual body weight. We'll do neuromuscular blockade for 24 hours, and we'll do optimal PEEP, titration of the maneuver PEEP every 12 hours, at least. We use the actual ideal body weight based on the height, and this is the tables which we use. And once we start, if the patient enrolled to conventional ventilation, we will set the tidal volume 5 to 7 ml per kilo. We'll make peak inspiratory pressure mandated for everyone less than 28 centimeter. Unless the patient have poor chest wall compliance, then we'll be accepting less than 32 centimeter. This is the I time, what we will set, and will be in the FiO2 necessary. We'll use optimal PEEP and PEEP recruitment. That will be discussed in the next lecture in more details after Dr. Marty. I'm done with that. So we'll continue the case. So don't leave until the next lecture.
So we'll have another lecture on ARDS by Dr. Mus'ab after Dr. Marty. Thank you very much, Dr. Muslim. So I don't think there is no one better actually than Dr. Marty to tell us about non-invasive ventilation. Dr. Marty Ponsodina is a senior consultant, pediatric intensive care unit. He is also coordinator of the pediatric home ventilation program in Barcelona Children's Hospital. Dr. Pons' main interest is respiratory care in critically ill patients and patients requiring long-term mechanical ventilation. His research field focuses on mechanical ventilation, especially non-invasive ventilation. Thank you, Dr. Marty, for being with us.
Thank you very much. Good afternoon. It's a great pleasure to be for third time here in Kuwait. The two other times were 2011 and 2019, and I was really invited to promote the use of non-invasive ventilation in your country through 2 days NIV courses that were very, very successful. So let's move on. So these are potential conflicts of interest. I'm not selling anything, just we had a mechanical NIV international meeting every 2 years in Barcelona, and we have a lot of sponsors that they are selling their machines, but I am not promoting any one of them. I'm just trying to sell the best knowledge to use all of them. So let me introduce my hospital. Sant Joan de Déu Hospital, St. John of God Hospital, belongs to a religious order that has many facilities around the world. And this is the Children's Hospital. It's a 300 beds children's hospital, and now we have a 37 beds cancer center. So the facade was recently refurbished, but because we have a long history in our city. So the brothers of Sant Joan de Déu, they have been working around the world, but in Barcelona for more than 150 years. Taking care of children, always. So this is my PQ. My PQ is, was refurbished 6 years ago. It's 24 beds. We are having 1,400 admissions per year because we are attending cardiac surgery, neurosurgery, all the acute infections, and all the taking care also of chronic patients. And I am also taking care of these patients when they went out of PQ, because years ago, pediatric pulmonologists having no clue how to do home mechanical ventilation. And I haven't also no clue, but I started to do because I have a little bit of knowledge on mechanical ventilation. And nowadays we're taking care of 200 patients at home. And the story begins more than 25 years ago. This is Judith. Judith is a 2-year-old young daughter that has a spinal muscular atrophy type 2. She was admitted because of respiratory infection and failed extubation for 2 times. So that's his solution. Let's go for tracheostomy. And the parents refused. Parents said, okay, we're not going to allow to connect our child all the life and the neck to a ventilator. And okay, we went obviously to the ethical committee to ask for support to save the life of the child. And the ethical committee agreed with the parents. So, okay, you cannot do the tracheostomy if the parents do not allow you to do that. So at that moment, it was, okay, we try, as usual, extubate to oxygen, and that's it, or try something new. At that moment, I was lucky that I had a short experience with stable patients, neuromuscular patients having spine surgery, starting non-invasive ventilation, because adult doctors coming, pulmonologists coming to the hospital to do that. Usually are teenagers, and they will help him. I was just a young, curious doctor looking at that. Okay. And okay, I thought, okay, I have an opportunity and something to offer to Judith. Hopefully for me, because I am here, she was successfully extubated. Now is 29 years old. She's going to marry now with her partner. So, and he's enjoying the life in an electric wheelchair, obviously, and using only the nocturnal NIV. So that was really challenging. It was the beginning of everything that led me to introduce in the acute critical care non-invasive ventilation, and later on develop the home mechanical ventilation. So, but we're going to talk about and to show you some ideas about the tricks of the trade about non-invasive ventilation. And we are using this acronym, that is ICEMAN, that tries to summarize this. What should I know? Who to apply, when not to apply, how to monitor and analyze the failure, and when is enough, so the next step. And we are teaching around the world using this acronym. We have been starting using in United Kingdom in 2015, and it was for an attendee. The attendee was asking for an acronym. It's even for me difficult in my language, so it was difficult, and the same attendee came the second day with this idea, and this gave us the idea of use the acronym, and we are very thankful for that. So let's move on. So I stands for identification and indication. C goes for contraindications. E goes for equipment. M for mode and monitoring. A for analysis, and N for next steps. So let's start with the identification. Very important. We should know which is the patient that we are going to put on NIV. So we should diagnose if it's a type 1 or type 2 failure. We should know where to start with this. It should be in a HDU or in a PQ. Never can be done in the general ward. That's for sure, because we need appropriate nurse-patient ratio. Then, so we also want to identify if our patients have or not ARDS, linking with the previous lecture. This is important. And what is important? Because we know from the literature that the average of success rate of NIV is around 20%. And what about in ARDS patients is 50%. Okay, with a Spanish and Portuguese study, when we start to use the non-invasive monitoring, the SF ratio. Later on, thanks to this very nice study, Pardy study, okay, we get a prospective cohort of 160 patients on NIV having the diagnosis of PRDS, and the success rate or the failure was around 50%. So these are very risky patients. We want you to be enthusiastic, not crazy doing an NIV. So be very cautious with these patients. So we are teaching our attendees just to identify those patients at higher risk of failure. And we realize that in many places, people don't have clear the idea of the 5 clinical points to this is an ARDS or this is not an ARDS. And we should really end up the course that people are doing that. Okay, what about general population? Hopefully we have from 2008, this is a Chilean group from South America. They did good research, a randomized control trial, general population, bronchiolitis, pneumonia, bronchitis, wheezing disease, whatever, and they showed that we are reducing 30% intubation rate when using non-invasive ventilation. Even with other ventilators, now we have better machines, we have better interfaces, but it's a randomized control trial. So even though there are not a lot of randomized control trials in pediatrics, but still we have the first one that was a good one. Here it is. But what about the use of, that is challenging, that can be risky, the indications for using NIV in ARDS? So we are lucky because after this PALIC group, we get this recommendation. I joined that, I was invited to participate. So it was a long journey, just reviewing, funding 185 papers talking about children's and ARDS with randomized control trials, good quality studies, but we couldn't only extract from 15 articles. So even though this is the highest level of evidence, so we are still, there is a scarcity of studies of good quality. Finally, we end up with 4 clinical recommendations, 6 good practice statements, and 1 research statement. So I'm not going to go through all of them. So just one of the important recommendation, and saying, okay, we suggest as experts a low level of evidence, you know. So that patients with possible PRDS or at risk of PRDS that we are using conventional oxygen or high flow nasal cannula, and we are seeing that there is a worsening of respiratory failure, we can offer a time limit NIV trial, CPAP or bilevel. Remember, although many think they consider this is non-invasive ventilation, this is non-invasive respiratory support. High flow doesn't give you and the patient ventilatory support. It's respiratory support, but it's not ventilation. So, and obviously being cautious, and there is no clear indication for intubation. So that's clear. If there is, the priority is the patient is at risk of respiratory arrest or whatever, you should proceed to intubate and protect and get the best outcome for that patient. Let's move on. So we are not going to see the contraindications because they are usually, the red lines are clear. How to apply this, Iceman, about the equipment. We have some bench studies, some clinical studies showing that there are no difference between the ventilators. So it doesn't matter you're using a specific NIV ventilator, could be Drager von Carina, this is V60 for Philips, and other ones, companies, compared to PQ conventional ventilators with NIV option. However, our nurses prefer these ones because the automatic triggers make the patient's life more comfortable and is reducing the nurse workload. So we are getting the same outcomes, but we are working less and more comfortably with specific NIV ventilators. When you can see here, we compared two periods, 2010 and 2016. And you can see here that using whatever we had, nasal cannula, this is a nasopharyngeal tube. Put it inside the nostril 7 centimeters to get close to the glottis and capture the inspiratory effort of the patient. So we are improving the synchrony, just putting the nasal cannula inside the nasopharyngeal zone. At that time, 65% of success rate. Okay, it's not bad, but when we moved with the same ventilators to this period, 2010, 2016, using the total face mask, we go up with the Servo U, Servo I, 85%, with the V60, 95%. That's pretty clear that we are increasing at least 20%, reducing 10% the intubation rate in infants younger than 6 months. So we are, although we don't have a randomized control trial, we are believers on total face mask. So that's it. Okay, that can be just some data coming also from the study. Okay, this is the period. So we were increasing the use of non-invasive ventilation. This is the combined use that those who failed on NIV and we use mechanical ventilation came down from 40% to this 17%. And what about using just mechanical ventilation from the beginning? We came down from 10% to 3%. So it is, and we did multivariable analysis because there are a lot of confounding factors. You know very well. This is Capita Haddock from Tintin Comics. We are very friends, and we are very happy with the results. But we did the multivariable analysis. We talked about the age, apneas, the previous use of high-flow nasal cannula in the general ward, and we end up that only one thing was really making sense. So when you are using other interfaces instead of the total face mask, you have an odds ratio of failure of 2.43. That's this 20% of increasing the intubation rate when you are not using it. The reason is because in small infants, you don't have very good oronasal interfaces. Probably, this difference is lower between in adults or in younger children that we have more oronasal interfaces. So I'm not saying if you have older patients and you can use, and you're using oronasal interfaces, that's very good. But the message is nasal cannulas, nasal masks usually are offering worse outcome to the NIV results, whatever the ventilator you are using. I think it's an important message for the equipment about that we have. Let's move to the modes. This is a randomized control trial for Another good friend is Christophe Milesi. He's also a fan of the Tintin comics. Most of the young people don't know about that, or only know about the pictures in Hollywood that Steven Spielberg did years ago. But very nice paper showing, okay, failure rate with CPAP, blue, 30%. Failure rate with high flow nasal cannula, 50%. And what is interesting is that the reason for failure was totally different. All these patients, almost them were increasing the risk because of increased work of respiratory work. And most of them were rescued by CPAP. On the other side, those who failed with that usually was for comfort. The comfort scale was increasing, and they switched to high flow nasal cannula. 92% of these patients going down to high flow, they succeed. So it means that we are not very good finding if a patient needs a CPAP or high flow, but if we should make a decision, we will be very much successful just going for CPAP. And just in case the patient is very strong, fighting, discomfortable, don't think about start sedation. Think about, let's move to high flow nasal cannula. Let's go down and send this patient very early out of the PQ. Discharge him. Usually we discharge after 6 hours in high flow, go to the general ward. It's okay, this is not a place for you. I have another PQ free that are very expensive, eye scars. Okay, let's continue. How to monitor the A, how we analyze what's going on. So that's very important, monitoring. It comes from a low-income country, so this is Malawi, and they show that using bilevel increased the mortality. But the general ward, there was no doctor at all. Nobody was monitoring the children. So the message is pretty clear. It's not about not using CPAP. It's you cannot use CPAP or bilevel out of the PQ without monitoring the children because it can be harmful and dangerous. So that's pretty clear. So how are we monitoring? We really we want to highlight the use of non-invasive monitoring. We have, thanks to Robert and Kemani, validation of the SF ratio. We are the clinicians, we are very good monitoring the work of breathing, the heart rate, the respiratory rate. We have several clinical scales for bronchiolitis, for laryngitis, for other conditions. We are used to manage them, and they usually identify very early that the patient is failing or not. And optionally, we can use the transcutaneous CO2. But I can tell you, the patient is telling you through the work of breathing all the time the blood gases. Reducing the work of breathing, it cannot be that the CO2 is going up. It's the major stimulus to increase the work of breathing is PCO2. So it means that it's not absolutely mandatory, but it can help. If you are at risk of rebreathing, etc., it can help. So that it's as much as important as contraindications. It's the end, the next steps, when it's enough. And we have some papers. We did this paper about factors related to mortality in children with bilevel, and we found is a observational study, also did in Spain, Portugal, and also with Turkish colleagues. And we saw it makes sense. If I have a patient with cerebral palsy, I have an odds rate mortality because in many countries, because ethical reasons, this is the ceiling of the roof, the ceiling of treatment. So we are not going to offer more treatment. So okay, we know that these patients have a risk of 50% of mortality. So when they fail, obviously they end up with trying to do a good, very palliative care. Otherwise, immunodeficiency, we know that are very risky patients. Most of them can end up with intubation. But the intubation and the mechanical ventilation is going to save their lives. 90% of them can die 1 month later with multi-organ failure. It means that they are not ending up by the respiratory failure. It's because we cannot recover for all the problems, the ongoing problems with this cancer patient or with immunodeficiency patient. So obviously, these patients also has a higher mortality. We have also observed the tachypnea, anamnesis, and admissions. These are more difficult to explain, but we know that these patients could be at risk. However, there are no studies in pediatrics showing or accepting that they have increased mortality or they have a problem with that. It's important.
2 minutes, Dr.
Yes, I'm finishing. So that's important. We said the consensus of, say, start NIV trial in ARDS patients that are risky, and you have 50% of possibility to fail. Whoa. But when to stop? So, and according to some papers, so you can see if after 6 hours of treatment, you are not improving that work of breathing, then you are buying tickets for having self-inflicted lung injury. This silly concept that appears in the adult literature, and that can be adding more damage to the lung. So be cautious, do the NIV trial. If you succeed and you see that in 6 hours the patient is doing well, continue on that. But whenever it starts to happen a worsening and increase of work of breathing, it means that the transpulmonary pressure of the patient is going very high. It means that the patient is doing self-inflicted lung injury. And the best option is to intubate them, get paralysis, and Dr. Musab explained very well, paralysis, rest for at least 24 hours or 48 hours according to the adult literature. That's important. In the other way, we have a problem. People are getting more scared about the winning, and we are doing it so smoothly that we are lengthening the stay in the PQ because we are winning from intubation to CPAP or to high flow or to, and we reduce the high flow very slowly, so it means that we are lengthening. And the step down, the ABC study is a randomized controlled trial run in United Kingdom, showed that high flow nasal cannula was lengthening the stay in the PQ, and the CPAP in the process was a better and shorter alternative to that. But if the patient is not having intubated, just is already in NIV, what we are doing? So we have data of showing that we are reducing 18 hours, so almost 1 day in the PQ of our patients, because what we are is including our nurses in this nurse driving protocol. So if the patient is stable and has no big problems, no other underlying diseases, if the FiO2 is below 40%, we are in 14.6 of PEEP, saturations are okay. It doesn't matter what's the time of the day or the night. The nurse can start and reduce the IPAP by 2 points. Just knowing that in the next 6 hours, if there is no increase of work of breathing, respiratory rate, heart rate, then she or he can continue on that. If something goes wrong, just one step back. It's a very safe approach. We have no intubations. We have no readmissions in the PQ. Just 18% of the patients really have to go back, and we had to do a slower process. So it's available in this address. We publish in an educational journal of intensive care of adults. And it's a thing I want to share because it's a better way to shorten the stay in our intensive care
Time
units.
is up.
Okay. So it's evidence-based, NIV. You know that we should do a trial on NIV. Interventions are important. Ventilators should work better with total face masks, and you should search for better ventilations with a better leak compensation. Remember, they are telling you that CPAP or it's high flow is not inferior, but look at this. This is very nice red car. High flow, it's expensive, but it's nice. But okay, don't trust those who are telling you that a Ferrari is not is not inferior to a Ferrari. I think it's talking about car is pretty clear. So both are expensive, but there is a clear difference between them. So that I think is 20% of difference is a lot. So non-inferior, it doesn't mean equal. So we know how to monitor. and we have to analyze. But if we are doing the analyzing and we are failing, you should think we have the appropriate training, and here we have already in Kuwait, for the third time, we did in Saudi Hospital, and we enjoyed 2 days of teaching and improving, and people coming from several hospitals to improve the average level of use of non-invasive ventilation. For those who are waiting for more and asking for more, in April, we're going to have our course that will be in this website very soon. Next week will be available. It's in Castilian and English, so don't worry about that. No need to speak Spanish or Castilian. Just with the English, it's enough. So, that's all. And think about future. What are you going to do with the blades of the laryngoscopes? Because no way, no use for it. Thank you.
Thank you very much. Thank you very much, Dr. Marty. I actually wonder what car is the mechanical ventilation. Is it a Rolls Royce? I think it's a bus. It's a bus. Thank you very much. Amazing presentation. We will come back, Dr. Musab, and we really want to know what happened in that case, and we're hungry for more knowledge in pediatric ARDS. Thank you.
Okay, thank you, Dr. Ahmed. So you guys back to ARDS. So let's start again. So the same case we have previously, if you guys remember. So this is the case. So question for the audience. Who remember how old was the patient? Wait, the gift from the moderator.
Yes, there is a gift from the moderator.
Okay, 3 years, correct. She
yes.
is 3 years.
You have water there? We can give you water. You don't have water?
So, if I to still 100%, this is the X-ray repeated. PEEP is, the night team went up to 14, saturation 84. That's real case. So refractory hypoxemia. So what should we do? So if we go again, if you calculate the OSI, is about 25. So 25 here. So we discussed the high frequency and proning earlier in the prospect, and we'll continue the same discussion. But how about this recruitment maneuver? What does it mean? And why is it gray? So they said they cannot recommend for or against. Who can recommend for here? Who would recommend recruitment? Okay, so you're against the expert who cannot recommend for or against. Okay, so I just don't like this statement, honestly. You have to say something for the team who's practicing at the bedside. Don't leave them in the blind. So if you go, let's discuss a little bit of recruitment maneuver. So what does it mean? What we want is to increase the transpulmonary pressure that will open the collapsed alveoli, improve the compliance, improve some oxygenation, and ideally decrease the ventilator-induced lung injury used in refractory hypoxemia. And there's two ways described in literature how they do recruitment maneuver. One is sustained inflation, and one is called staircase inflation. I will discuss them in the next. So sustained inflation, this is just example of what people, when they say sustained inflation in the literature, they increase the PEEP to 40 centimeter for 40 seconds. The maximum recruitment happens in the first 10 seconds, and then you have to watch for hemodynamic instability. Other people describe going to PEEP of 20 with the peak pressure 20, and you decrease the rate to 4 to 6 seconds, increase the inspiratory time to 4 to 6 seconds, so you're giving very large, long breath with PEEP of 20 centimeter for 2 minutes. Other, less likely, they describe what we call sigh breath, is very high intermittent PEEP. It's not practiced, but these two are practiced widely. The other one is the staircase inflation. This is you increase the PEEP gradually until you get what we think is the optimal PEEP. So if you go in the literature, there's a big randomized controlled trial in adult about recruitment maneuver. So what they did is they increased the PEEP to 25, then for 1 minute, then they go to 35 for 1 minute, then they go to 45 for 2 minutes. You guys said recruitment. Somebody say recruitment here? Yeah, so you guys do this the same what they did here? Okay, so After this, what they did is they go down with the PEEP to 23, then they decrease until they reach 11 centimeter every 4 minutes. What they found is they found this maneuver increased mortality for those patients. Another big trial at the same time, it is done by some people are here on the other side, in the adult, Yasin Arabi, John Fraser present there. What they did is they increased the PEEP to 20 centimeter, then 30, then 40, each for 2 minutes. Then they increased the PEEP down to from 25 by 2.5 for 3 minutes until the saturation dropped by 2 or they reach 15 centimeter. That's another maneuver they describe also. What they found, they said it did not reduce the duration of ventilation or 3 days or mortality, no difference. But they found that it increased the hemodynamic adverse hemodynamic events. So there's some issues with it. After that, there's many big 3 meta-analyses combining all the adult data about the recruitment. What they found is there is no consistent difference in mortality. Some people describe there's decreased rescue use of adjunctive therapy such as nitric oxide or ECMO, and it is obviously associated with higher rate of hemodynamic compromise. How about pediatric? If you look at pediatric, there is absolutely no randomized control trial for recruitment in pediatric ARDS. There's a few studies. There's the biggest 3 trials. Collectively in these trials, there's 57 patients with ARDS, but they use what we call staircase recruitment maneuver. So they increase the PEEP by staircase, and they found variable effect. Some people found improved oxygenation, some people found no benefit. So there is even variable benefit in pediatric ARDS. Let's go back to, this is, I don't know, I just wanna, if somebody missed it, it is the pediatric ARDS consensus, which was published recently, PALIC recommendations. They're free, you can access it. So let's go what they said again about recruitment maneuver. They said, we cannot suggest for or against the use. Okay, so they cannot suggest, but they left a remark here. So they said, careful recruitment maneuver may be applied. So what does careful mean? We are always careful as intensivists, right? So still we don't know what's careful. This is some vague, they want to try to be away from recommending what should they recommend. What they said, slow, incremental, and decremental PEEP step, but they didn't say. And what they said is sustained inflation. Remember sustained inflation, which we discussed before? They said it should not be, they recommend against that, at least sustained inflation. If you want to do recruitment, consider staircase PEEP. So if we go back to our study, the prospect trial, we discussed this part initially. I lifted this one when we left the case. The patient is desaturating. We don't know what's the optimal PEEP. We want to do recruitment maneuver. So what we do in a prospect is PEEP titration staircase step to find the optimal PEEP by these steps, which I will discuss next. So you know, if you learn more about the ventilator-induced lung injury and the mechanism, you need to know about this important curve, the pressure volume curve. This is the red line when we inflate the lung. It's called the inflation limb. And the blue line is the deflation limb, when the lung is deflating. Understanding this curve will allow you to understand very fundamental point, which is called here the lower inflection, the point which the lungs start to recruit and go up, and the upper inflection point where the lung is hyper inflated. You need to stay away from either hyperinflation or the upper part of the curve, because this is the area of overinflation, and you need to stay away from the lower side of the curve, because this is the area of atelectatic trauma. Remember that, or know that there is only small area of safe zone of ventilation, which is happening here at the deflation limb of the curve around this area. This is the area which is the least injurious for mechanical ventilation. This area is remarked by continuous recruitment and de-recruitment. So if we need to set the optimal PEEP, we should be around this area. So the rationale we use in prospect is staircase inflation. And the rationale to use that is By using the saturation, which is inferring the end expiratory lung volume, is the PEEP recruitment or the onset of lung recruitment, the PEEP hyperinflation or the onset of hyperinflation. On the deflation limb, we also can identify the area when the lungs start to de-recruit, and we can identify the safe zone, which is the optimal PEEP. So how do we do it at the bedside? Practically, this is the way we do it at the bedside for the prospect trial. So you have pressure volume curve. We start with the lungs. Remember that PEEP is 14, and we don't know what's the optimal PEEP for that patient at that time, at that particular stage of the disease. It's changing by time. So we start with the PEEP. We increase the PEEP by 2 centimeters every 5 minutes, and we are monitoring the saturation. So we keep increasing until we get the saturation. So that is called PEEP recruitment. That's the lower inflection point for that patient at that time. Okay, so what's the next is we need to know the PEEP hyperinflation. So we keep increasing the PEEP every 5 minutes, watching the saturation. The saturation keep improving until we hit a point where saturation will no longer improve, or blood pressure will come down, or compliance will get worse. That's called PEEP hyperinflation. So now we need to come back again on the deflation limb to see when the lung will de-recruit at the deflation limb. So we'll come down by the PEEP by same 2 centimeters every, slower now, not as fast as we're going up. Slower is every 10 minutes. We come down, saturation will improve because we are less hyperinflated at this stage. We keep going down. We keep going down until we get saturation. So that's called PEEP de-recruitment. So the optimal PEEP is around this time, or this is the safe area. So now we need to set the patient 2 centimeters above PEEP of de-recruitment. But we need to go back to hyperinflation to recruit the lungs and then set to optimal PEEP. So what we'll go again to PEEP hyperinflation, which we identify for 1 to 2 minutes, and then set the PEEP 2 centimeters above PEEP de-recruitment. We do it every 12 hours in prospect, or as needed when there is any issue with desaturation. So the same thing, if the patient is assigned to high-frequency oscillation, it is the same concept. But instead of PEEP, we use mean airway pressure. So we started with the mean airway pressure. At this area, this is when the saturation improves. We will monitor this as mean airway pressure recruitment. We keep going up until saturation no longer increase or decrease, or hemodynamic instability. Same thing, will be hyperinflation. We decrease every 10 minutes by 2 centimeters. Saturation will improve. In de-recruitment, saturation will decrease. Then we'll go back to hyperinflation. Okay, and then we'll set the mean airway pressure at that time 2 centimeters above mean airway pressure de-recruitment. I hope that's clear. So if the patient is assigned to high-frequency oscillation or randomized to high-frequency oscillation, this is what we will set. We set the FiO2 to target this saturation. As we discussed earlier, we're going to use very high frequency of 8 to 12 based on blood gas. We will use higher amplitude than usual because we believe that this pressure will be dissipated in the endotracheal tube and proximal airway, and it is not as injurious as low frequency. So we set amplitude or delta B between 60 to 90. We start with the mean airway pressure as usual, 5 to 6, but if the patient is not improving, then we increase and we do the titration to know what's the best mean airway pressure. We set the I time as usual and the bias flow per age. This is the recruitment maneuver I discussed earlier. I think this is the mapping of the mean airway pressure as we discussed in the previous slides. This is a study done prior to starting a prospect by many prospect principal investigators, Dr. Curley, Myra, Martin. What they want to do is what they want to see is what most of the patient with severe ARDS require during this mean airway pressure titration. What they found is that when they're doing the mean airway pressure titration, most patients will require around 37 centimeters at the time as a PEEP of hyperinflation to end the hyperinflation. And when they are coming down in the deflation limb, most patients will require around 27 centimeter. So when we do the titration, don't be afraid of the pressure. We can sometimes reach 37, 38 during the recruitment. And in those studies, there's no hemodynamic instability or air leak or other injuries if you do it safely and slowly. Of course, it takes time because you need to stay 5 minutes each step and then coming down 10 minutes each step, but it's very helpful for that patient. If the patient, once we continue the high-frequency oscillation, we do mean airway pressure, aggressive mean airway pressure titration to know the lowest mean airway pressure every time. We don't leave the patient. It's around 6 to 12 hours. We have to do mean airway pressure titration, as we discussed earlier. If the patient, in terms of frequency, the goal is the highest frequency to achieve pH 7.1 to 7.25 to 7.3. We increase the frequency to reach maximum of 15 hertz before we lower the frequency. If it is 15 already, then we decrease the power to decrease the amplitude. If the patient is desaturating 85%, we need to rule out any physical issues like occluded, dislodgement. And if the patient is still desaturating, then we can do the PEEP titration. If you have if you're concerned about over-distension, you can think about this as a mean airway pressure hyperinflation. And you don't have to increase, but you have to come down as a deflation limb every 10 minutes to see if the saturation improves. This is the recruitment. We do it as frequent as needed. And if the patient is acidemic, then we first increase the delta P, and if the delta P if the power is 10, then we decrease the frequency by 0.5 to 1. When do we convert to conventional ventilation? If we reach mean airway pressure of 15 to 20 centimeter and FiO2 50, this is mandated to switch to conventional ventilation. Then we continue with the conventional ventilation protocol. This is what we discussed earlier, the same target. What we do is we do PEEP titration. We ask the nurse to target the FiO2 of 88 to 92, so she must decrease the FiO2 to target that saturation. Every 6 to 12 hours, as a physician, you need to match this PEEP FiO2 target. So if the nurse wean the FiO2 down to 50% and the PEEP is 14, then you have to come down because this is not matching the PEEP FiO2 table. We also, if there is any issue of desaturation, you have to do mapping again for the patient with going up and going down, 5 minutes going up, 10 minutes going down to know the optimal PEEP for that patient. If the patient is hypoxemic, then we do PEEP titration. If you did PEEP titration, it didn't work, then we can increase the pressure, increase the tidal volume if the peak pressure is still within limit to give a little bit more mean airway pressure. And if no improvement, then you can think about overinflation. You can come down in the PEEP to see if that will improve the saturation. The same thing here for saturation. If the patient is oversaturating, to wean. If the patient is acidemic, pH less than 7.15, arterial pH less than 7.15, then we increase the rate first. And if it's not working, we can increase the tidal volume if the peak inspiratory pressure is still within limit. If patient have pH more than 7.3, we first wean the peak pressure before we wean the rate as a protective lung ventilation. So once the patient reaching oxygenation index less than 8 or oxygen saturation index less than 7.5, now we move from acute phase management to weaning phase, okay? So at this stage, the target will be more liberal. So we target saturation 92 to 97%. We target pH 7.3 to 7.4, and we are looking at the best PEEP, and we wean aggressively to assess extubation. When is he ready to extubate? So what makes the patient ready to extubate? These things. If the patient is spontaneously breathing, if the oxygen saturation index or oxygen OI less than 6, and there is improvement in lung compliance, this patient must be tested for extubation readiness. What does extubation readiness mean? Means, how you do it, we set the FiO2 at 50%, we set the PEEP at 5, and then we evaluate the patient saturation. If he's okay, then we put him in pressure support. Pressure support based on the ET tube size. You have either 10 for small size, 8 for a little bit bigger size, and 6 for more than 5 centimeters. So we put pressure support, and we monitor 3 parameters. We monitor saturation, exhale tidal volume, and respiratory rate. If the patient meets these 3 criteria for 2 hours, which is saturation above 95, tidal volume at least 5 ml per kilo, and respiratory rate within physiologic range, this patient passed and must be extubated. Okay? If the patient is still sedated, we need to repeat the test, wean the sedation, and repeat the test in the evening at 4 p.m. and extubate if he passed. If he doesn't pass from pulmonary because he failed from these, we need to repeat the test again in the morning. This patient initially randomized to prone positioning for 16 hours. This same patient which we discussed earlier in the prospect. This is the prospect form. The patient was this day 0, the patient day intubation. Patient day 15 was extubated, stay in ICU for 4 days, and then discharged. This is the X-ray before discharge from ICU. You remember the same X-ray? This is real X-ray. I'm not faking it, not from Google. The same patient. And I thank my ICU for bearing with me for the following all the protocols. You can see here the protocols and the same protocols on the wall. We're following it, and we are actually, even if the patient is not agreeing to be randomized to prospective trial, we follow the same protocols because this is what our standard of care, either conventional high frequency, either prone or not, but this is what we, as a guideline, agree to do. Thank you very much for your time.
Thank you very much, Dr. Musab. Amazing presentation. Thank you. We're back with Dr. Marty Pons, and we'll talk more about what other strategies when high frequency fails in critically ill patients.
So I'm very glad that many of the questions I'm going to raise and share are very similar or not the same, or the same that Dr. Muhammad was telling you, so that even though we are not agreeing in everything, but in many important things we are making an agreement. So I have no conflicts of interest related to this picture. We can skip these ones we saw. And these are the topics I'm going to discuss with you. So high frequency isolation, waiting for the evidence, what I need to know about conventional ventilation to manage hypoxemic patients. After that, I will introduce the electric impedance tomography that we are using for 2 years now. It's a new toy or a good tool. We'll see in the future. I don't have the answer yet, and we end up with the take-home messages. I just want to advertise so that most of the information that comes here comes for a truly a big effort from European experts on the field that we manage under the umbrella of SMNIC Society to do this handbook of pediatrical and neonatal mechanical ventilation. And this is the second edition, and it's available as ebook. So it's really, really, really affordable and interesting. So I'm lucky that these authors came with this study that is a systematic review and meta-analysis about the use of high frequency in children. So, and they did a very good analysis, and there are 2 tables that are very interesting because they separated and divided like the outcomes according if they are randomized trials or observational studies. And that's very interesting because, okay, thinking about barotrauma, pneumothorax, pneumomediastinum, it seems that those patients with high frequency isolation, we are reducing a little bit the risk of barotrauma. That's good. But what happens in observational studies? Those we are not experts on the field, perhaps the fellow that is in the night shift on Saturday or on the summer holidays is doing that, is following the protocol, but has no expertise. What we're seeing, okay, we are going up to 100 per 1,000 instead of 600. So if people are more confident, are better trained with conventional ventilator, we have less barotrauma that with hypoglycemia. So, and this is real life. That's what you are doing. We are not usually here. So, interesting. Let's look at the mortality. I think it's even scarier. So again, if we are in the middle of randomized control trial, that's good for the patient. Okay, we are reducing slightly the risk of mortality. But what happens in real life when people have not a good training or they're not using frequently the device? It seems that we are increasing the mortality. Okay, and we are reading the papers, the literature, the evidence, but we are not applying properly. And if we are not applying properly, we are not getting the same results. Sometimes we are getting the contrary, and it's really harmful. That is really scary, at least for me. So the conclusion of the authors is very polite. So the scarce evidence currently available does not allow to conclude that high-frequency isolation has advantages. Okay, the two tables that I show you is telling more than there are no advantages. It can be risky in bad hands. So we are not saying that it's a bad tool. We are saying that it's risky in real life. It's okay, be aware of that. I have to tell, I introduced high-frequency isolation in the unit years ago. We have been using many years. We have now an ECMO program. We are using nitric oxide. And we are using more and more recruited maneuvers in the same way that you show in the prospect protocol. And we start to do not use high-frequency isolation because we're getting the same. The alveoli don't care about the machine. If you are recruiting with a staircase maneuver, recruitment maneuvers, you are opening the lung and you're rescuing a lot of patients. A few patients still going in ECMO. 90% of them end up on high frequency as a rescue, but most of them end up on ECMO. So usually we are not, perhaps we have lost the skills and the ability to do very well the high frequency, and at the last moment, we are failing on that. So to be honest, perhaps this is what's happening. But okay, better and using more PEEP and using better recruitment maneuvers according to the adult literature, better results, similar results than the adults, and less use of high frequency isolation. So, okay, what should we need to know how to manage in conventional ventilation? So we know about the FIO limits. That's pretty clear for all of you that you know that above 60% there is toxicity. I'm not sure if everybody's so aware about that above 80% you are inducing absorption atelectasis. And then what happens? You have at the night shift, at the end, you have a beta PAFI ratio. And you say, okay, I improved the PAFI ratio. But what happens 2 days later? The patient is worsening because you are with a FiO2 of 100%, you are inducing more atelectasis, you are inducing more damage. Perhaps in your next night shift, the patient will be worse and is going to be on ECMO because you were using too much oxygen. So be aware about the nice numbers in the PAFI ratio that I did in my night shift because it's not about the end up and the follow-up of the patients. So all are advantages, and so let's move to prone position. So we know by this table in the handbook that there are many advantages about improving oxygenation, reducing the risk of barotrauma. So we have increased recruiting some atelectasis, improving the VQ mismatch. So that's and many other things. So, and the important thing is when we are seeing, and we know from adult literature, that prone positioning is making a difference. Not in all the patients, only in those that the perfect ratio is below 150. Only when you are very ill, the prone position is going to change really the situation. So prone position is not for everybody. It's especially for a moderate to very ill ARDS patients. So the important thing is, wow, in the PARDI study, they were recruiting more than 700 patients, 160 on NIV, and they found that only we were using the prone position only in 10% of our patients. I think it's shameful because it's very cheap, it's very useful, it has risk of extubation, of course, if you are not doing properly, but I think that, okay, according to the known benefits, I think that, okay, the balance, even though we don't have enough evidence, I don't know, I understand. He was complaining about the PALIC, so saying that the recommendations. I have been involved in that panel that time, and it was tough because I was trying people to get more, but the rules were very clear. We cannot do statements without evidence. We are just talking about the 15 articles we found that have the highest level of evidence. Other things are opinions, and we cannot go into do statements on opinions. So that's the rules, and unfortunately, then we get still blind. So that okay, they are because the problem is that you cannot get a high agreement with some of the sentences because people have very different opinions. That's expert consensus. This is black, this is white. So at the end, you end up with a sentence that is gray. So, and perhaps it's not useful. I agree absolutely, but this the way it works if you want to do something that is based on evidence. So it's not, okay, you can have your opinion, your experience, your observational studies, but it doesn't matter. So the question is about what you have seen. Okay, what about the recruitment maneuvers? I think that we know now that the adult literature is showing, okay, you are not having a lot of pneumothorax, like 3% only. It's not very common to have big complications, but it seems that long term, we are not increasing or reducing the mortality, and some studies are saying, okay, on the contrary, we can be increasing the mortality, so it means that, okay, according to the literature, we cannot recommend them if are increasing the mortality. That's the reason at the end we add this with that remark of, okay, we think that the staircase maneuvers can be useful if cautiously used, but don't go for the 40-40P maneuver. So that I think, and is that what we are doing also in my unit. And I think this is that some studies have shown reduction of mortality. We're human beings. When reading the literature, we are picking the chairs that we like. So that's the reason for meta-analysis and just putting all together and to do a better studies and know and be closer to the truth. So this is the Hodgson procedure that these 2-3 steps are made more rapidly in order to shorten the time and make then this steep process as you were explaining very, very well. I'm not going to go on detail on this, but you explained very well. So nothing to, we agree absolutely that are very useful. The risk is very low, and together with prone position, I think that are good tools to improve the oxygenation of our patients. Probably we're not reducing the mortality, but we are getting the patient in a better position, and probably we are reducing the use of nitric oxide, that is expensive drug. And what we know from the literature that at the end of the day, after 3 days, you are not improving even oxygenation. You are not reducing mortality. In adults, we know that we can have more kidney failure. But I think that's important just to highlight that in pediatrics, you have many patients with hypoxic pulmonary vasoconstriction, with pulmonary hypertension, with patent foramen ovale. These patients are very hypoxemic. If you reduce the resistance and reduce the pulmonary hypertension, you get a change in the flow between the side auriculas, and you improve a lot the oxygenation without changing nothing in the ventilator, without changing other things. So I think that we should keep in mind that 20% of the infants, 25% of the infants, they have a patent foramen ovale. So we can just increase the oxygenation just using this simple drug that is going only to the ventilated areas. Let's talk a little bit about the new toy that I have in the... So we got a donation in the hospital 2 years ago. There are several devices in the market. More than 10 years ago in adults, Draeger launched this. I saw for the first time in the mechanical ventilation conference in Montreux in Switzerland, organized by Professor Peter Riemensberger, and I thought, oh, this is like for research, it's very important, it's very expensive. I'm not going to use never ever in my life. But I think, okay, it's interesting tool to see. So happily, now we got it. We get this is a Brazilian company, Timple. There's another one, Best Medical. I think there's another Chinese company on the way, also with pediatric belts. And how it works. We are putting a belt that has 16 to 12 electrodes in contact with the skin, and they should, according to the adult literature, in T4, for pediatrics in T5, T6. So it means we are looking at a slice of the lungs. Basically, we are looking at the basal lobes. We have information about the regional distribution in the air in the inferior lobes, not the upper lobes. So it's not a general scan that you have. How it works? These belts, they have like electrodes that are sending a very low level of current that is under the sensitivity of threshold. So nobody is feeling nothing. It's not radiation. It's not painful. And then 2 of these electrodes are sending information through the thorax. And according to the level of density of gas, of water, etc., you are collecting the data in this rotatory direction, and it's transformed to a virtual image pixel to pixel. And the color is grading. This electrical gradient is compared to a gradient color. So this is insufflation. This is more collapse. And if it stays gray, if there's no change. So it's breath-to-breath information. And because the patients are tachypneic, sometimes it's confusing. And after 2 minutes, you get like a functional image. It's like a picture every 2 minutes of which is the situation of your lung. And you have the percentage of air in that area by quadrants, by anterior, posterior, left and right. So you have a lot of information about that. Additionally, you have the plethysmograph information, so the change of the signal, electrical signal, and this correlates with the tidal volume. So these are arbitrary units. So these are not microvolts, this is not milliliters, this is nothing. It's arbitrary units made by the engineers, so that we don't know exactly, but it's transformed to this image. You can see here a patient with obliterans bronchiolitis. So, and you can see here that the X-ray, I don't have the image here, was symmetrical, no collapses in the right lung, but you can see that the right lung was not participating at all in the ventilation. This patient ended up going to Valdebron Hospital for lung transplant because it was almost impossible to ventilate. You can see here the peak pressure were 51, we reached 60 of peak pressure. It was almost impossible to get the air going in. So what about the plethysmograph sign? You can see here the change, as I told you, this delta zeta called, it's changes in ventilation, it's tidal volume. But it's more information. The height that I have from the baseline, it's called expiratory end lung volume. This correlates with the FRSC. So if I have an ARDS patient, I increase the PEEP and this goes up, it means I am recruiting the lung. On the other side, if I am an asthma patient, I decrease the respiratory rate, I am going to this side, I am reducing the air trapping. So according to what you have underlying disease, you should interpret what happens with the EELV. So that's pretty clear. So let's move on. So we can analyze and see real life what happens if you are changing, we're doing postural changes. Coming from right decubitus to supine, we can see that this is a decrease of the EELV. We can see a summary of the change, and we have increased the tidal volume and the volume in the right lung, because this is like the CT scan. You are looking from the feet. So this is right, this is left, okay? This is up, this is down. And you can see a summary. There is increase of the tidal volume in the right lung. Let's see another example of postural changes. So you can see a right atelectasis. The patient is in prone, we put in supine, no changes. We go to left lateral, and we have an increase of both sides, even the left is the left, we are getting a better FRSC. So we are monitoring a simple thing that is the postural changes, the physiotherapy, the recruitment maneuvers.
2 minutes, Dr. Martin.
Yes, I'm finishing, thank you. So this is a very nice recruitment maneuver as you are doing, Musaf. So 2 minutes, step increase of the PEEP going up. You can see here the PEEP going up every 2 minutes. Because it wasn't an ARDS, we went only up to 16, so with a peak pressure of 31, and going down. And you can see, meanwhile, you are going up, the left lung is hyperinflating and is losing the interchange of air. And when going down, it means that you have recruited more lung and you are increasing the tidal volume. And you end up with a higher ELV in the right lung. So it means that it can have you, after that, regional information that you can confirm by X-ray. Sorry. You can see after that we have increased the volume in the right lung, and the atelectasis has improved of Sapir. So it's not only useful for ARDS, we can use recruitment maneuver for big atelectasis. So summarizing, high-frequency oscillation is increasing mortality in many observational studies. That is scary. That evidence at the end doesn't favor its use, but we are using in rescue, especially in patients with pleural leaks. The prone position is safe, cheap, and reduces mortality in some studies. Recruitment maneuvers, we are promoting them. This is a staircase approach, and the prospective study is doing, but using that caution. We do not recommend to do every 12 hours. If you get your objectives, keep calm, stay. If nothing happens, don't, because at the end, you are probably risking to damage this lung. So we have the potential of this tool, but we don't know. We are working on that. We are trying to get published our first experience with 25 patients. We will see in the future. So thanks for your attention. Yes, if anyone is interested, this is the link for the editorial of our handbook. Shukran. Thank you very much.
Thank you very much. Yes, please. Dr. Musab, hayak. Thank you very much. It was actually amazing lectures about non-invasive ventilation, pediatric ARDS. We are open to some questions. Maybe we'll take a couple of questions before the break. If anyone has the questions, we have someone there. Actually, yeah, you can raise your hand again. Yeah.
Thank you very much for this highly informative session. Thank you, Professor Marty and Professor Musab. I want to ask regarding the POW on FOW ratio. Should we rely on arterial readings or can we use venous readings? This is my first question. My second question, PaO2 on FiO2. Should we rely on the venous readings? Should we rely on arterial readings and we cannot use the venous readings? Sometimes we don't have arterial readings. This is the first question. My second comment regarding the other maneuvers to improve the hypoxemic lung injury and hypoxemic respiratory failure. We have a good experience in airway pressure release ventilation as a mode, it seems like recruitment mode for us. We are using it in severe hypoxemia with PaO2 on FiO2 ratio less than 100, and it works a lot, especially with pulmonary edema. In cases of pulmonary edema, cases needs renal dialysis. Usually we put on APRV till insertion of Mahooker and preparing for dialysis. It works very, very good, and we have a good study on this published in Egypt, and it is highly successful in those cases for 12 to 18 hours till dialysis done. Then we turn on the patient on the conventional modes, and we are going to wean the patient within 24 hours. It's highly successful in hypoxemic respiratory failure, not responding to increment of PEEP or recruitment or stair maneuver for recruitment. Thank you.
Thank you, Doctor. So the first question about the hypoxemia and checking the oxygen. So we cannot use the venous saturation. It's not reliable. You can use instead SpO2. And as we say, OSI, oxygen saturation index, very reliable as long as the SpO2 less than 97%. If it is above 97%, not reliable. So you have to wean the FiO2 if the SpO2 more than 97%. There is some concern in dark color skin whether SpO2 is reliable or not, especially now. That's one of the secondary analysis after the prospect. We will see if that's going to be different, but that's not the primary. So I don't know. But for now, venous is not reliable, either arterial or SpO2. APRV, airway pressure release ventilation. I did not comment about it, and I said I was hoping that nobody will ask about it. Dr. Aaron Bansal, he left or he's here? Actually, if you look, even in Balik, they did not recommend about it. What is a big randomized control trial done by Aaron Bansal in India in 2019. They randomized about 102 patients for APRV versus low protective ventilation, and they found increased mortality in APRV. We don't know why, but you can actually Google Bansal APRV. You can read. There's a lot of nice, rationale why is it. The concern sometimes is the release tidal volume, or tidal volume is variable. Patient on pressure support or automated compensation, they might violate the protective ventilation. I don't know. Marty, do you want to?
No, have experience.
Yeah, so these things, or the high pressure, the inverse can cause. So that's why they found increased mortality. That's why it is not commented and not recommended. Yeah, but as an evidence-based, it increased mortality compared to conventional. Maybe you can look at that study and see what they use as a methods and whether is it different to what you did. I don't think somebody will replicate that study again. Yeah.
Thank you very much, Doctora. Thank you. Well, maybe we'll take one last question, actually. Go ahead. Please go ahead.
Amazing talk to both. Just a comment for both you guys. Marty, the data are not so good for cancer patients, but the number of cancer patients treated outside the ICU and receiving non-invasive ventilation is still high. What is your current practice? If we should follow the data, we should go from oxygen therapy when it's failed directly to intubation. But I still do non-invasive ventilation and check. This is for you. Instead for Musab, I follow the prospect as well. But I think still some knowledge is missing. One of the things that you mentioned briefly is the compliance of respiratory system, which goes in parallel, but sometimes goes not in parallel to the recruitment maneuver. A comment on this from your side.
So the use of non-invasive ventilation in cancer patients, it's challenging, but at different situations. I think that we all are facing a lot that the patients that have fluid overload that can easily be rescued with NIV plus furosemide. So it means that, and it's totally different. So bone marrow transplant with a super infection or whatever. So what the literature says is that, okay, you can do NIV trial, obviously in the PQ, in expert hands, but if you feel that are failing, you are not, then early intubation is better. It seems that the information that the data that we have that prolonging that NIV trial is giving you, reducing the chances and reducing the survival rate. So it means that, okay, it's not against doing NIV trial, but be cautious and follow what we're seeing here. So 6 hours, it's enough to clarify if it's responding or not.
So Matteo asked a very important question. He said, once we do the titration, sometimes we follow the saturation, but sometimes also the compliance. So the tidal volume will drop, pressure will go up. So at the same time, maybe saturation will go up. So what we have in ARDS is heterogeneous lungs. Some of the lungs is hyperinflated already. Some of the lungs are normal, and some of the lungs collapsed. So when we are doing the titration, we may end up with more hyperinflation, more worsening the compliance. But what's the priority for us at that time, at that stage? Are we having no issue with carbon dioxide and we can tolerate hypercapnia and still the peak pressure is still within an acceptable range, and we want to just maintain higher mean air pressure to achieve a little bit of oxygenation? If that's the issue, I will go with the saturation. And even if the tidal volume go down to 4 ml per kilo, I will definitely also make sure the peak pressure does not violate the limit. But tidal volume from 6 to 4, as long as CO2 will go up and maintain a little bit of higher mean air pressure to achieve oxygenation. If I have issue with acidosis, then I cannot lower more, I cannot violate. It'll be hard time. Where do you worsen the compliance at the same time worsening oxygenation? You will end up in ECMO. If you are at that stage, it's very hard. You can't win. But if you still have issue with hypercapnia, no issue with hypercapnia, you can follow the oxygenation, even if the tidal volume will drop. So I would not follow the compliance if the saturation is my sole target and I have no issue with acidemia.
Dr. Musab, Dr. Marty Pons, thank you very much for being with us, and thank you all for attending. Will we go for 5 or 10 minutes break? Yeah, we'll go for 5 minutes break, and we'll see you back for our last 4 lectures. See you.